All right, so today we're going to talk about some miscellaneous inflammatory conditions. And so we have a chest radiograph that shows bilateral consolidations. Patient also has fever. Of course, when you have bilateral consolidations, the first thing you have to think about is pulmonary edema. And when we look on the CT, what can we say about these consolidations? They're predominantly what attenuation? They're what?
High attenuation?
No, not high attenuation. What do we call this?
Oh, like ground glass?
Yeah, these are predominantly ground glass opacities, right? You can see the underlying lung architecture through the opacities. So it's predominantly ground glass. Again, it could be pulmonary edema. There are other things in the differential. If the patient had hemoptysis, you might think about diffuse pulmonary hemorrhage, of course, multifocal pneumonia. But besides bacterial pneumonias, there are other types of infection that also consider when you have especially ground glass opacities like this in multiple lobes. So what are we talking about? What kind of infection?
Viral?
Yeah, so viral pneumonias. So what viral pneumonias might patients show up with?
Flu, COVID?
Yeah, now, especially those, this was influenza A, swine flu viral infection in this particular patient. So when you have ground glass opacities, in addition to those other things, especially if there's signs of pneumonia, or signs of infection, you should also consider viral infections. And so, we're all familiar with the patients who come in with ground glass opacities, especially if they're peripheral like this. Here's another example. This is an example of COVID pneumonia. So COVID has a tendency to give you peripheral consolidations. It can progress rapidly. In this case, you could see what happens in a week in this particular patient. And then for the typical findings of COVID, peripheral bilateral ground glass opacities, they might also have crazy paving, they might also have consolidations. And then, I've given you this, but there are other findings that might also be associated with COVID. But the most typical are these peripheral ground glass opacities that we see with COVID. So here are some examples: COVID, peripheral ground glass opacities here. Another example with peripheral consolidations. And it can resemble organizing pneumonia because that can also give you peripheral consolidations. Here's an example of influenza A pneumonia, somewhat more diffuse in terms of the ground glass opacities there. Okay. One other thing to remember about COVID is it is associated with increased tendency to clots. So you can see that there's a PE here. Do we see any other evidence of clotting?
Like arch of the
Yeah, the arch of the aorta, right. There's a tiny thrombus there too, okay? So these patients do have an increased incidence of thrombi with COVID. All right, so here's a patient who has fever and respiratory symptoms, history of exposure to white powder, letter received last week. First, what's the finding on the chest radiograph, or what are findings here on the chest radiograph? Yeah, so what do we think the wide mediastinum is caused by?
Lymphadenopathy.
Particularly where? What part of the mediastinum?
paratracheal.
Right paratracheal, yeah, this is really wide over here. Anything else we see here? Besides the wide mediastinum, probably from lymphadenopathy, anything else abnormal?
The right.
Yeah, it's the right perihilar consolidation, all right? So given this history, what is it we're supposed to think about here?
Anthrax.
Anthrax, yeah. So, naturally occurring, it's pretty rare, right? So most infections are in livestock. Human anthrax also, when people are infected, tends to be cutaneous infections. So pulmonary infections are unusual, but they can occur. But Anthrax can also be weaponized. So the spores tend to clump up, but they can be treated so that they're declumped and so very small and then easily inhaled. And so that's so-called weaponized anthrax. And so that's when there's an increased propensity to have pulmonary infection. So these spores are ingested by macrophages, but they still travel to mediastinal nodes, and symptoms can occur about 1 week after exposure. So these spores produce, or the bacteria produces a powerful exotoxin, and that's what results in mediastinitis and hemorrhagic lymphitis. So mediastinal lymphadenopathy, and then consolidations that kind of radiate out from the hilum. So these people can be very sick and can go on to develop shock. So mediastinal widening for lymphadenopathy, perihilar consolidations, pleural effusions, these are all findings that you might see. Here's some more examples. Mediastinal widening, pleural effusion, again some mediastinal widening and perihilar consolidations here. And so what might we see on CT is hyperattenuating nodes on non-contrast CT from hemorrhage, consolidations that radiate out from the hyla, and also this peribronchovascular edema, pleural effusions. Pleural effusions might also be hemorrhagic in these patients. And it can be very rapidly progressing, as in this example here. Here we can see the hematocrit effect, blood layering out, so this is hemorrhagic pleural effusion, lymphadenopathy here producing mass effect on the pulmonary veins, and then you can see the perihilar opacities. Right. Nodes can also be enhancing, as in this example. So pleural effusions, lymphadenopathy, hemorrhagic nodes, hemorrhagic effusions, and then here also we can see peripheral enhancement in these lymph nodes also. You can see that also with tuberculosis. So, but hemorrhagic nodes will be hyper-attenuating on non-contrast CT. That you don't see with tuberculosis. Okay, so this patient has chest pain and fever. So as we look at the chest radiograph, what can we say about the chest radiograph? What do we have? What'd you say? So what do you think that is? Well, I guess chest pain and fever. Pneumonia, right. So it looks like there's a consolidation there, so we're worried about pneumonia. Is that the only place? So where would that be? What lobe? Yeah. So why do you say upper lobe? You don't know how to describe a straight line that goes, yeah, right. So it seems to be bordered on the minor fissure, right? So I would place it in the right upper lobe. So it looks like that this patient has consolidation. So, of course, you're going to be thinking about bacterial pneumonias, et cetera. But there's another finding. At first we see that, there is a central line there. But there's another finding on the chest radiograph that really helps you. Can anybody see what the other finding is? Kevin, you're doing MSK.
I was gonna say there's the central venous catheter.
Well, yeah, right.
MSKY.
MSKY.
Let's see.
The vertebra,
What about the vertebra?
H-shaped.
Yeah, so these vertebrae are H-shaped, right? See that? It can be subtle on the frontal view. So what does that tell you? Yeah, so the patient has sickle cell disease. So maybe a little bit of sclerosis of the left humeral head right there on the edge of the film, right? So often, they don't give you this history when you're looking at the chest radiograph that a patient has sickle cell disease, right? So if we see that in association with consolidation, so what is the diagnosis then? Acute chest syndrome, yeah. Right, so acute chest syndrome is associated with sickle cell. It accounts for 25% of hospital admissions and deaths related to sickle cell disease. So fever, chest pain, consolidation on chest radiograph, elevated white count. They may not have consolidation on admission, but you can develop it a few days later. So they will have chest pain and crisis. So it can be caused by pulmonary infarction, vaso-occlusive disease as the cells sickle within the pulmonary microvasculature, or it can be brought on by infection, by pneumonia, which then can also result in increased sickling of cells. And so, your typical organisms that might cause pneumonia in these patients. So what happens is if there's sickling of cells in the pulmonary circulation, there's increased blood viscosity, decreased tissue perfusion, leads to acidosis, which leads to more sickling of the blood cells in the pulmonary circulation. So you get into this vicious cycle, and the patient can develop, it's how they develop the crisis with acute chest syndrome. So we might see consolidations. The consolidations can be the infection itself, can be hemorrhagic edema, can be hemorrhage, cardiomegaly, enlarged pulmonary vessels. The clue is, though, the underlying history that the patient has sickle cell, but you need to be able to recognize any findings on the chest radiograph associated with sickle cell, because you might not immediately get that history, especially when you're looking at emergency room studies. So you look for the bony changes of sickle cell disease. Bone infarcts, especially in the humeral heads, H-shaped vertebra, and that's from necrosis of the end plates. So if we do CT, we might see consolidations or ground glass opacities, hypoperfusion in the periphery, something else you might see with CT. You might get a CT scan for PE on these patients, right? And you might see this hypoperfusion in the periphery as a result of the sickling of the cells. So the H-shaped vertebra, much easier to recognize on the lateral view. You can see the H-shaped vertebra pretty easily on the lateral view, but you might just have a portable frontal view. So you have to be able to recognize that on the portable frontal chest radiograph also. And this is what it looks like on CT. Of course, pretty easy to recognize, especially if you're looking at a sagittal CT. So not only do you have H-shaped vertebra, but you also have this kind of sclerotic modeling of the bones, right? So the sclerotic bony changes are also typical of sickle cell disease. So is another patient with sickle cell disease. Do we have to say anything about the chest radiograph? Where? Yeah, so heart's kind of, I guess, borderline enlarged, but this shadow here represents what? Yeah, so that's the descending thoracic aorta. What could this be? So this guy here is, right atrium. There's pulmonary vascular congestion, which is not going to surprise you. But so this, what is this line here that's displaced? Well, first you have to tell me what line would be displaced. So paraspinal line, and so the paraspinal line would be pointing you to what compartment? Posterior mediastinum, right? So your differential for posterior mediastinal masses? Neurogenic tumors, paraspinal abscess, and of course the thing you mentioned. Yeah, so if you're thinking about a posterior mediastinal mass, it's somebody with sickle cell disease, right? So first, if you're just looking at the CT, what tells you that the patient has sickle cell disease? What is that? Yeah, what do we call that? Yeah, so this is autoinfarction of the spleen. You have a small calcified spleen, so that, of course, is associated with sickle cell disease. Okay? The bones are somewhat sclerotic looking, the vertebrae here, right? Of course, we can also see that. And what can you say about the paraspinal mass? Well, do you see the mass here? So what are characteristics of it that are associated with extramedullary hematopoiesis?
So that's some fatty component.
Yeah, it has fatty components down here, right? So you see that there are fatty components within it. And that, of course, is associated with extramedullary hematopoiesis, right? Anytime you, also the bony abnormalities, right? So anytime that you have a paraspinal mass associated with some kind of bone marrow abnormality, abnormalities in the bones, think about extramedullary hematopoiesis. And so that's the case here. It's a patient with sickle cell with extramedullary hematopoiesis, right? And then more findings of sickle cell here. We talked about the autoinfarcted spleen. Notice the sclerotic looking bones. And then here within the humerus, you have avascular necrosis. So avascular necrosis of the humeral heads, also common finding associated with sickle cell disease. Often on the plain film, it manifests as sclerotic humeral heads. Okay. All right, so this patient has chronic cough. Anything abnormal on a chest radiograph? Gave you a close-up. Parabronchial thickening, maybe some patchy opacity here at the lung base. And then here's the CT. So what can we say on the CT? Yeah, so you have bilateral consolidations in the lower lobes. What's the attenuation?
Fatty attenuation.
Yeah, so these are fatty attenuation consolidations, right? So your diagnosis is what?
Lipoid pneumonia.
Lipoid pneumonia. How do patients get this?
It's like mineral oils.
Yeah, so aspiration of mineral oil. So typical scenario is usually an elderly patient might have esophageal motility issues. Could be achalasia, could be reflux. And so they might take mineral oil for constipation, and then they aspirate the mineral oil. So aspiration of the mineral oil then results in these chronic consolidations with their fatty attenuation. So this is lipoid pneumonia. So if we see these fatty attenuation consolidations, you can see the very low numbers there in the fat range. So that is lipoid pneumonia. This can look like a cancer sometimes because of the spiculated borders on the lung windows. So there's a term that is used if you have lipoid pneumonia. You can tell it's lipoid pneumonia, it's fat within it that looks like a mass. What's the term for that?
Paraphenoma.
That's called a paraphenoma. Yeah. So lipoid pneumonia results from aspiration, usually of oily substances. We've talked about the typical scenario, and they can develop a desmoplastic reaction around it from proliferation of fibroblasts, and so that's what can result in the spiculated borders and the organization around the consolidation. That's why it can look like a mass if you're just looking at the lung windows, paraphenoma. So you can easily mistake it for a tumor. It's important to notice that the attenuation, it's important to notice the fatty attenuation within it. Then we can say that it's lipoid pneumonia and not a tumor. Okay. So consolidations on lung windows, but fatty attenuation when you look at the soft tissue windows. So that's important for making the diagnosis. So this is a 42-year-old man who's HIV positive. The chest radiograph, of course, shows what? Where?
Lower lobe.
Yeah, so left lower lobe, looks like left lower lobe pneumonia. What's the most common cause of pneumonia in HIV positive patients?
Strep.
Yeah, just community-acquired pneumonia. So just strep pneumonia is the most common cause of pneumonia. So there are various infections that we need to think about in patients who are HIV positive. All right, so we'll talk about some of these and what their manifestations are. Neoplasms also to consider, and then lymphoproliferative disorders, and sometimes even pulmonary hypertension can occur in these patients. It is, if you're thinking about what's the cause of the abnormality on the chest radiograph, knowing the CD4 count can help you. So, especially whether it's greater than 200 or not. If it's around that range, you think about greater than that, you can have bacterial pneumonias. With tuberculosis, you tend to get the immunocompetent pattern of changes with TB when the CD4 count is greater than 200. Upper lobe fibrocavitary disease when the CD4 count is less than 200. That's when you tend to get more lymphadenopathy. And then the more unusual infections, atypical mycobacteria, pneumocystis, fungal infections, they tend to occur with much lower CD4 counts. MAI, CMV, very low CD4 counts. And then also when you get to the lower counts, you can also think about neoplasms like lymphoma and Kaposi's sarcoma. So knowing the CD4 count can sometimes help you in terms of what pathology you're thinking about when you're looking at the chest radiograph. So for the community-acquired pneumonias, they can occur at any level of immunocompromise, but especially if the CD4 count is greater than 200. So these patients are 4 times more likely to develop bacterial pneumonia than the general population. And your typical organisms, of course, strep pneumonia, the most common organism that you might get in these patients. So they can have single or multifocal regions of consolidations. In patients who are HIV positive, it's more likely to be multilobar. So you have left perihilar consolidation in this patient. Here's more extensive pneumonia as it progresses rapidly in these patients. Other infections, Pseudomonas pneumonia, this can give you cavitation, as we see here. Patient who's HIV positive, has fever, look at the chest radiograph. Can we say anything about the chest radiograph?
For capacities, and things like this, so cafeteria.
Yeah, so you have these kind of vague opacities, right? So you have these vague opacities. It's kind of hard to figure out exactly what's going on, right? You have these vague opacities on the chest radiograph. So you should have a low threshold for doing CT on these patients, especially when, what we get as far as the chest radiographs in ER are just the portable chest radiographs that can be very hard to interpret. You get these vague opacities. So then you get the chest CT, and what does it show? So what test should we recommend next? What?
Blood culture. Blood culture.
Well, what imaging test?
Outlet imaging.
Yeah, somebody said, well, what do we consider? What do we think this is?
Septic.
Yeah, septic emboli. So you might recommend echocardiography next, right? So these cavitary lesions, so they're also prone to develop septic emboli, and this can be very subtle on the chest radiograph. It can be very hard. I mean, you look at the chest radiograph, it's hard to say exactly what's going on. It's surprising how much worse the CT looks than the chest radiograph. Again, a lot of it is because you're dealing with portable chest radiographs from the emergency room. Okay. So the lesson is in these patients, make sure you have a low threshold for doing CT if they're concerned about pulmonary issues. Right? Another patient who's HIV positive, here's the chest radiograph. What do we think? Where? So right hilar lymphadenopathy, anywhere else?
Yes,
So where in the mediastinum, particularly? Oh, right paratracheal, right? Look at all that opacity there. So the lungs themselves look relatively clear, right? So what's your differential for lymphadenopathy in a patient who's HIV positive?
Tuberculosis.
Tuberculosis, anything else? Lymphoma, anything else? Also, atypical mycobacterial infection, especially if the CD4 count is low, right? If the CD4 count is very low, atypical mycobacterial infection can also result in lymphadenopathy in these patients, right? Here's the CT scan on this patient. So what is the CT showing us?
Necrotic lymph nodes.
Yeah, so we have these low attenuation nodes with peripheral enhancement. Also looks like there's some inflammatory infiltration of the fat. So what would you favor for this patient?
Maybe still TB.
Tuberculosis, yeah. So this is the appearance of tuberculosis, low attenuation nodes with peripheral enhancement. Okay. So with tuberculosis, if the CD4 count is greater than 200, they tend to get an immunocompetent pattern on the chest radiograph, upper lung cavitary disease consolidations. If the CD4 count is less than 200, even though the disease probably represents reactivation of old disease, they will get that immunocompromised pattern of lymphadenopathy, consolidations, effusions, especially lymphadenopathy. Low attenuation lymph nodes with peripheral enhancement, like we see there. So the upper lobe cavitary disease, this is associated with an immunocompetent pattern in patients with tuberculosis, right? You could see that even in patients with HIV, if their CD4 count is greater than 200, as opposed to lymphadenopathy. Here we have right paratracheal and right hilar lymphadenopathy from tuberculosis. And this is associated with the lower CD4 counts. And with TB, you can have these low attenuation lymph nodes with peripheral enhancement. Now, atypical mycobacteria can also affect these patients. So here it can manifest predominantly as lymphadenopathy with very little in the way of lung disease, hilar and mediastinal lymphadenopathy, minimal parenchymal disease, and they might also have low attenuation nodes, just like you can see with tuberculosis. Also, they can have lymphadenopathy within the abdomen, mesenteric and retroperitoneal lymphadenopathy. So atypical mycobacterial infection also belongs in your differential for lymphadenopathy in patients who are HIV positive, and they can also have lymphadenopathy within the abdomen, in addition to adenopathy within the chest. So this is a patient with atypical mycobacterial infection before antiretroviral therapy. This is 1 month after antiretroviral therapy. What has changed on the chest radiograph?
It's worse after antiretroviral, like more infiltrates on the
So
left side.
maybe some perihilar consolidation. What about what's happened here in the mediastinum?
increased lymphadenopathy.
Yeah, so it looks like there's increased lymphadenopathy. So what am I showing you here? What does this represent?
Reconstitution of the immune response.
So 1 month after antiretroviral therapy, you can see that the lymphadenopathy can progress in these patients, even though the infection itself may be controlled. This is called immune restoration syndrome. So it's a transient clinical worsening that we can see on the chest radiograph in patients, in HIV patients or AIDS patients with underlying infection or inflammatory disorders. You can also see it in patients with sarcoid, AIDS patients with sarcoid, who are given antiretroviral therapy. So as the immune function improves, then they develop the changes, the increased lymphadenopathy in these patients. So here's a patient with tuberculosis. You can see that after they're started on therapy, the consolidations have worsened in this patient. So that's called immune restoration syndrome. Okay, here's a patient who's HIV positive. What do we see on the chest radiograph?
It's quite long capacity.
And what are you gonna call them? Well, there are consolidations, right? So we have bilateral consolidations, right? So, you talked about, what this could be pneumonia, pulmonary edema, if there's a reason for that. In addition to bacterial pneumonias, we said we also consider viral pneumonias, right? Which can also do that. The CT on this case, though, shows mostly ground glass opacities. And if on the CT we have predominant ground glass opacities, then we think about pneumocystis pneumonia. So don't forget about pneumocystis pneumonia also in these patients. It's a cause of atypical pneumonia. So you might also be the first one to suggest that the patient is HIV positive if you happen to notice on the CT scan that the consolidations are predominantly ground glass. So maybe they haven't done an HIV test on the patient, but the patient comes in with, severe respiratory symptoms, and on CT they're predominant ground glass opacities. Doesn't have the other findings that you would associate with pulmonary edema. Of course, viral pneumonia is also in your differential, right? But don't forget about pneumocystis pneumonia. So you would recommend that they do an HIV test on the patient. There's another finding that's also characteristically associated with pneumocystis pneumonia. What is that? Nematoceles, right? So these patients can also develop nematoceles from pneumocystis pneumonia. So this represents air these aren't really cavities. This is air that dissects into the interstitium in these patients. So they develop these air collections there. And then these can resolve over time, right? So these are nematoceles. You might see that on the chest radiograph also as these air-containing collections. Okay. So this pneumocystis pneumonia acts like a protozoan classified as a fungus. Most common when CD4 count is less than 200. Respiratory symptoms, chest X-ray is going to be abnormal in most cases, although it might give you an interstitial pattern. Ground glass opacities, especially on CT, tends to be bilateral. And then some of these patients can go on to develop nematoceles within the lungs. Chest X-ray can also be negative or have very subtle abnormalities, but it's on the CT that you see the ground glass opacities. So pneumocystis pneumonia also belongs in your differential if you see bilateral ground glass opacities in a patient who's HIV positive, or you might suggest that they test the patient if you're thinking about this. Okay? So pneumothorax is a complication if they develop nematoceles, right? And often these pneumothoraces are large and refractory to treatment. They can be very hard to treat. These patients don't heal very well. So pneumothoraces can be a complication from nematoceles in these patients. You can see the extensive air leaking here into the soft tissues, pneumomediastinum, even with the chest tube, these patients are prone to develop persistent air leaks. So this can be very hard to treat. Another patient who's HIV positive, what does the chest radiograph show? Well, this represents, what are you going to call that, first of all? That's a pleural effusion, right? So there are some opacities here within the lungs. If you look very carefully at them, though, what do you notice? Yeah, they're kind of nodular, right? So you have these small nodular opacities within the lungs. What could this be?
So like TB.
So somebody mentioned miliary, right? Miliary disease, miliary tuberculosis. So certainly that might be one of the first things that you think about. But in terms of miliary disease and miliary infection in patients who are HIV positive, what are other things to consider besides tuberculosis?
CMV.
CMV might give you small nodular opacities, although it's more likely to give you more of a consolidative appearance. Anything else? Atypical mycobacteria. Anything else? How about fungal infections? What fungal infections? Yeah. So Cryptococcus. So it's the most common fungal infection that, if you're excluding pneumocystis, associated with AIDS. So it's associated with low CD4 count, can be associated with cryptococcal meningitis, right? Can give you a miliary pattern of infection also with multiple small nodules, right? So in addition to TB, also consider fungal infections like cryptococcus. Sometimes you can develop abscesses from infections in the lung. This is a cryptococcal abscess that's occurred in this patient. Okay. Aspergillosis can also occur in patients with AIDS. They can develop invasive aspergillosis, cavitary lesions. So we've talked about invasive aspergillosis. Here are some examples: cavitary lesions, halo signs, so from invasive aspergillosis. So this can occur in patients with AIDS. They can also develop airway invasive aspergillosis, where it can affect the trachea, but it can also extend down into the smaller airways, kind of give you tree and bud or this kind of a bronchopneumonia pattern of opacities there within the peripheral airways. So that can also occur with aspergillosis. CMV pneumonia, somebody mentioned that. That can give you diffuse ground glass airspace consolidation. Sometimes reticulonodular pattern can easily be mistaken for pneumocystis. It's a very difficult diagnosis to make because it requires recovery of CMV by cultures, inclusion bodies, and biopsy samples of for definitive diagnosis or progressive pneumonia in response to antiviral agents. What can complicate matters is often they can have CMV superimposed on other infections. So you may be looking at, two infections occurring at the same time, but CMV superimposed on some other infection. But with CMV, we tend to get ground glass opacities like that, and consolidations can look very much like pneumocystis in these patients. Bacillary angiomatosis, unusual infection here. It's cat scratch fever. So these patients can present with skin lesions that mimic Kaposi sarcoma, and they can also have fever, night sweats, cough, occasional hemoptysis. It can mimic Kaposi's with endobronchial lesions, parenchymal nodules, pleural effusions, mediastinal lymphadenopathy. So this is something to consider in patients with skin lesions resembling Kaposi sarcoma. So it can give you nodules like this within the chest, as we see there. There's another patient who's HIV positive. What are the findings here?
Scattered nodular opacities and interlobular septal thickening.
So we have interlobular septal thickening, right? These opacities are predominantly where? Yeah, so perihilar, right? Kind of bronchovascular opacities like that. And you have these, other additional nodular opacities here too, right? So when you have a patient who's HIV positive who has this bronchovascular distribution of opacities like this, what do we think about? Yeah, so Kaposi's sarcoma can give you perihilar opacities like that. The catchphrase that's been used with that is what? Flame-shaped. Yeah, flame-shaped opacities with Kaposi's. So probably caused by herpes virus. And so 90% of patients will have skin lesions. So if you're thinking about this based on what you see on CT, it's important to ask if the patients have skin lesions. They can also have airway involvement. So it's the perihilar distribution, the bronchovascular distribution of opacities. They kind of have a very angry appearance, right? So that's why they're called flame-shaped irregular borders. So that peribronchovascular distribution of opacities is another example where they're kind of distributed around the perihilar regions. Right? These can be hypervascular, so they will enhance after contrast. So perihilar distribution of opacities in patients who are HIV positive. This is something that will make you think about Kaposi's. Another patient who's HIV positive. What do we have here?
Rounded peripheral opacities.
What are you going to call those? What do you call a rounded opacity of a chest radiograph? Nodule or mass, right? So here's a patient who has multiple nodules or masses, right, in the lungs. What could this be? Well, lymphoma, what are other things? What else is in your differential? Metastatic disease? Anything else? Could it be infection? What infection might give you round nodular opacities like that?
Could be like early septic emboli.
Well, septic emboli before they cavitate, right, might give you nodular opacities, right? Well, we discussed an infection that might present as nodules. What infection? What fungal infection if patients are HIV positive? We have to get your short-term memory checked.
Cryptococcus.
Cryptococcus, right? We just went through that, right? So certainly that's in the differential. Could this be lung cancer?
Yes.
So patients who are HIV positive, what's important to know about lung cancer in these patients? They can develop lung cancer just like anybody else, but lung cancer in these patients also tends to be very aggressive, right? So that's certainly something else that you might consider also, right? But in terms of neoplasms, when we're talking about neoplasms in patients in HIV positives, the two neoplasms that we consider are what? You mentioned one, lymphoma, and we covered another one also. Kaposi's, right. So those are neoplasms that primarily affect, or you need to think about in patients who are HIV positive. This was an example of lymphoma. And so it's usually non-Hodgkin's lymphoma. It's the second most common intrathoracic malignancy in patients with AIDS. Usually they have low CD4 counts, tends to be very aggressive. The intrathoracic disease is commonly extranodal, so they don't have to have lymphadenopathy. So that's why they can present mostly with parenchymal lesions. So it can't present as a solitary nodule. In some cases it might cavitate. They can also have lymphadenopathy. We talked about lung cancer. Lung cancer in these patients tends to be very aggressive. So they tend to be poorly differentiated, rapidly growing, and very aggressive if AIDS patients develop lung cancer. This is a 12-year-old who's HIV positive. See anything on the chest radiograph? Let's give you a close look. What do we see on the chest radiograph?
Nodular opacity.
Yeah, so we see these small nodules, right? So what could this be?
TB, AIDS.
So could be, you think about tuberculosis, fungal infection, right? In a child, what does the CT show?
Cystic formation.
So we have a couple cysts here. What about the nodules? Can you say anything about the nodules?
Perilymphatic.
Why do you say perilymphatic?
Because it goes all the way to like the pleura.
It's what?
It like touches the pleura.
Yeah, they touch the pleura, right? But that could also be random. So why do you say perilymphatic? Well, here, it looks like they're outlining what? What's being outlined there?
The minor fissure.
No. Yeah, the secondary pulmonary lobule. Looks like they're outlining secondary pulmonary lobules, right, which would make them perilymphatic. Okay. It's an important distinction, right? If they're random nodules, you would think what? TB or miliary infection, right? With perilymphatic nodules and cysts, especially in a child who's HIV positive, now what do we think about?
Lymphocytic.
LIP, yeah, lymphocytic interstitial pneumonia. So that's also associated with patients who are HIV positive. So these are lymphoproliferative disorders that can occur. So LIP is a very common one. There are others that I've also listed here, but LIP, and that's the one that tends to be associated with perilymphatic nodules and cysts. So LIP represents proliferation of polyclonal lymphocytes throughout the interstitium. And that proliferation might result in air trapping, which results in the small cysts that we see in these patients with LIP. Interestingly, this does not progress to lymphoma in AIDS when these patients develop LIP. You can have varied appearances. You can have nodular opacities, as you see on the chest X-ray, nodules here, like we see on the CT scan. You could have lymph nodes, but the cystic lesions, that tends to be the most specific appearance for LIP that can really help you in terms of the diagnosis if you see cystic lesions. So LIP is a cause of cystic lung disease. Can be associated with HIV, although more often we see LIP associated with what? Sjogren's, yeah. More often it's associated with Sjogren's syndrome. Right. So you can have peribronchovascular nodules or that perilymphatic distribution of nodules, and you can have cysts associated with this, with LIP. There are other lymphoproliferative disorders that can also be associated with HIV. These would be very difficult for you to diagnose prospectively. So another patient who's HIV positive, what are the findings here on the CT scan? Yeah, so you have these enlarged axillary nodes here, also mediastinal nodes, and you mentioned that they are enhancing lymph nodes. So what are three causes of enhancing lymph nodes in patients who are HIV positive? What could it be? So Castleman's disease is one, the other two are? No. Kaposi's and bacillary angiomatosis, right? So those are three causes of enhancing lymph nodes in patients who are HIV positive. Multicentric Castleman's disease, Kaposi's, bacillary angiomatosis. So multicentric Castleman's disease, it's a proliferation of B cells, again, reaction to herpes virus. CD4 count usually less than 350. Can also be associated with Kaposi's and non-Hodgkin's lymphoma in these patients, so enhancing lymph nodes. And they may also have peribronchovascular nodules, but enhancing lymph nodes. Enhancing nodes is the finding that's associated with Castleman's disease, regardless of whether the patients have AIDS or not. Here's another patient who's HIV positive. What are the findings here?
AP window, there's patchy consolidation of the right lobe.
All right, so let's go through our bumps. What is this guy here?
The arch of the
Yeah,
aorta.
so that's the aortic knob. There's another bump here, right? So what could that be? So you thought it was lymphadenopathy, but could it be anything else?
Mass,
What?
like a mass.
Mass? Could it be anything else besides mass?
Pulmonary artery.
So how are you going to tell whether that's pulmonary artery or whether that's lymphadenopathy?
Lateral.
What do you notice on the lateral? There's no donut on the lateral, right? What is this guy? That's the left pulmonary artery. How do you know? It's going up and over this, which is what? Can't hear you.
Left main bronchus.
Yeah, left main bronchus or left upper lobe bronchus, right? What is this guy? What?
Left main pulmonary.
No, this is not the left main pulmonary artery. What is this? Lateral chest radiograph. What is this thing? What makes this shadow on the lateral chest radiograph? We covered this in the first lecture as the right hilar vascular complex, but in this case, this is going to represent what? That superimposition of the main and the right pulmonary artery on the lateral chest radiograph. Right? You can also see that the right pulmonary artery is somewhat enlarged. So putting all this together, it suggests that this shadow is what? Is that lymphadenopathy or is that something else?
It's enlargement of the pulmonary.
Which, what pulmonary artery? This would be, this bump is what? Not left, but main pulmonary artery. This is enlargement of the main pulmonary artery. There's another finding on the left lateral chest radiograph that also tells you that you're dealing with pulmonary artery enlargement besides the pulmonary arteries. What is that finding on the left, on the lateral chest radiograph?
Left right ventricle.
Enlargement of what?
Right ventricle.
Right ventricle? How do you know?
You lose the retrosternal clear space.
The heart's too tall, right? You see the encroachment on the retrosternal clear space here. The heart's not enlarged on the frontal view, but on the lateral view, the heart is too tall, right? So you see all of this. So this is enlargement of the right ventricle and the right ventricular outflow tract, encroaching on the retrosternal clear space. So putting all this together, we think the patient has what?
Pulmonary artery hypertension.
Pulmonary artery hypertension, yeah. So this is the chest radiographic appearance of somebody with pulmonary artery hypertension, okay? And this can also be associated with HIV. See the enlargement of the main pulmonary artery, left and right pulmonary arteries here on the CT scan. So it's a patient with HIV. Pulmonary artery hypertension, very small percentage of patients with HIV, but they can get it. It's probably plexogenic pulmonary arteriopathy, similar to idiopathic pulmonary artery hypertension in these patients. But an enlarged main pulmonary artery and large central pulmonary arteries in patients who are HIV positive, we can consider pulmonary artery hypertension. And so the findings, big main pulmonary artery, big right and left, enlargement of the right ventricle, right atrium, right ventricular hypertrophy, all of these are the findings associated with pulmonary artery hypertension. Why does the right atrium enlarge in patients with pulmonary hypertension, pulmonary artery hypertension? Tricuspid regurgitation, yeah. So in patients with pulmonary hypertension, a tricuspid valve is not going to handle that very well. So they develop tricuspid regurgitation, which is going to give you the enlargement of the right atrium. And that's also how on echocardiography they estimate the pulmonary artery pressure. They measure the peak velocity of the tricuspid regurg, which tells them what the pressure gradient is between the right atrium and the right ventricle. And they assume that that pressure in the right ventricle reflects the pressure in the pulmonary artery. Okay. 22-year-old man, HIV positive. These are T2 weighted MR images. What's abnormal?
Cystic lesions in the anterior mediastinum.
What?
Cystic lesions in the anterior mediastinum.
Yeah, cystic lesions in the anterior mediastinum. So what organ do you think they're in?
Thymus.
Thymus? What is this called? multilocular thymic cysts. So these can also occur in patients who are HIV. These resemble the lymphoepithelial cysts, so in the parotid glands that you might also see in these patients, septated multiloculated cystic masses in the anterior mediastinal multilocular thymic cysts. Okay, so that's what we've covered today. Any questions? Okay.